I think we gave you guys some really good opportunity to ask questions based on some of this. So we're going to open this discussion up for questions. If you have a question, I'd ask you to line up behind the microphones. There's microphones on each aisle. And we'd be happy to entertain questions that folks have. I think. Yes, and if you just say who you are, where you're from.
Yes,
please.
I'm Lisa Culver from the American Physical Therapy Association, and I just wanted to ask a question or make a point of an area of health disparity that is incredibly hard to deal with because it crosses geographic and cultural areas, but those are for individuals with physical disabilities who are immediately at higher risk for health problems. It's issues of transportation, built environment, you name it. So, and I do understand the difficulty because as we know as practitioners, every individual is different. But I just would like to hear your thoughts about how you might incorporate that into some of these initiatives.
I'll be happy to start. I think one of the things that we've got to do is to, first of all, thank you for that question, because I think there are some populations who don't get acknowledged in doing this work. But if we can make the case that we all benefit by making improvements in the environment for some populations. So for example, California is a place that has a lot of advocacy around people with disabilities. And one of the, not that other places don't, it's just a place where I live, and I know that I experienced that a lot. And so, for example, there's been a lot of focus around the cutting out the sidewalk so that people in wheelchairs will have easy access. Well, not only does that population benefit, but I travel a lot, so I go there when I'm carrying my luggage across the cities and I'm running to get a taxi. I benefit from that. Mothers with babies in baby carriages benefit from that when they're trying to get their babies across the street. So if we can make the case that we're all benefiting from a certain idea, that it's not just singularly focused, although that should be legitimate in its own, but again, making the bigger case that we'll all do better when we all have an opportunity to do better for some populations. That could be one way to address it.
Don?
There's one small instance of this in our work that came up, which was very curious for us. We presume that in an inner-city site with a large grocery store and a parking lot, that someone's thinking about buses and someone's thinking about public transit and access. And landlords do not automatically think that way. There's a presumption that the bus is on the street, and when you have 4 acres of parking and later you decide you'd like the bus to stop at the front door, if you've done your site work improperly, that you cannot be approached by an articulated bus. So we had hundreds of thousands of dollars that we had to raise post a store opening to be able to get the bus up to the front door because it was an accessibility issue. There was so much parking that the walk from way out there in, or the wait out there with your groceries spoiling in the sun in the summer is a horrible experience. And they wanted the bus to be able to pull right up front, but there was a swell in getting into the parking lot. The bus couldn't navigate. So, city officials didn't think of it, the grocer didn't think of it, the landlord didn't think of it, and that's now changed our work. We ask questions in underwriting projects now about not just can people get to the store, in terms of access, but can public transit also get to the store?
Thank you, Don. Yes, sir.
Dan Other, U.S. Department of State, Office of Global Food Security. This question is going to push you a little bit beyond where the panel originally was, and I really appreciate your presentation, but I'm trying to look for models that we can take beyond a little bit globally, learning from what we know in the U.S., and I'm curious, some of the things that I didn't hear in this discussion from best practices that we've developed in terms of development practices around the world. The process needs to be, in our case, country-owned. It needs to come from the people who want the process to occur. So I would imagine in your case it needs to be a community-driven process as opposed to an external intervention. The second is that you need to take care in development not just of the immediate issue, but the underlying problems that contribute to the immediate issue. For instance, if we just give people food, but we don't take care of the underlying poverty, then we're not moving forward in development, we're just doing a humanitarian relief effort. So I'm curious if you could speak to those two things in your programs here in the States. How are you coming from programs that are initiated by the community, and how are you coming at programs that don't just meet that immediate, let's solve the NCDs issue, but actually address the more fundamental underlying issues that are some of the causes of this?
Well, I think each of us mentioned quite robustly community engagement in our work. So I think your first question we answered quite well. We could give more about it, but each of us in our work is constantly seeking community accountability or community engagement in our work. A grocery store is not going to be received well if that site was sacred land for something else, or if there was some other more important priority for the community, and that's their 10th priority. I think the sustainability question of giveaway versus sustainable program, we're addressing that by financing sustaining profitable businesses in communities that once we've got that plate spinning, we can leave and the business works. Other programs, I don't know what your thoughts are, but I heard a lot about relationships and the idea that building community relationships, whether it's with authority or with hospitals or with insurers, relationships they're sustainable. Like that, well, I think what we're saying about that is it's not transactional, it's lasting. Mm-hmm. And I think we should probably hear more, maybe.
I'll say two things about that. One is that the strategies that we're working on in community are policy and environmental changes for a reason, because we think those are more sustainable and more likely to stick around when the funding's gone. And then on top of that, for Kaiser Permanente, we're bricks and mortar in that community, so we're not going away. So even when our funding, if and when we're still in our initiatives, but when our funding goes away, there's still people employed, there's still people that are our members, and so there's a long-term investment in that community through more than just the funding of that obesity prevention mm-hmm. effort, and there's a way to leverage our assets because of that in ways that are possibly unique.
And before I turn to the next question, I just want to say, we've seen, just like I was talking when I first got up and talked about the excitement I feel in this community, and Michelle Obama helping connect with people and people really thinking about health and wellness in new ways, that has really gone internationally. I don't know if you've seen it, but we've had visiting royalty come to our office, talk to us about what they can do, and foreign governments, and so I think there is a lot of momentum, especially with the popularity of some of our core figures, to really help push some of these ideas out. So thank you for your question. Thank you for your work. Chris, I think you were next. Do you want to?
Hi, I'm Chrissy Economos. I'm a member of the Roundtable. First, I want to thank you for successfully delivering a thought-provoking panel. It was really terrific. I have a question first for you, Pamela, with respect to the dose calculation. I'm really glad to see you're doing that. I think many of us struggle with scaling up evidence-based strategies that we know deliver a dose in a smaller setting, and how do you do that on a large scale? When you put up the physical activity and you showed the percentages from each of the individual strategies, how are you accounting for compensation when you put all those things collectively together and deliver them to a child?
Sorry, I missed one word. How are you allowing for compensation?
Yeah, each individual thing may deliver a certain dose, but in your thinking about the calculation and the modeling, how are you accounting for the fact that it might not deliver that additive dose when you put it all together?
Yes, and we grapple a lot with that and haven't resolved it, but we have an advisory committee of evaluation experts throughout the nation that one thing that we grapple with is it additive? Is it synergistic? Is there synergy? And so we haven't fully addressed it, except to say that right now we're adding it, and we don't know if there's more to it than that, and we also don't. Our strategies aren't hitting each kid in that school, in my example, but they're hitting across the population, and so that's why we work on getting the most kids and getting the most strategies across, and a combination of the right things, but it's imperfect, and So for now, we're just looking for associations. So I wasn't looking to match the 9% with the 5% that was measured. I was looking for the association. They're both going in the right direction. They're both, they're both meaningful. One's 9%. That's strong, but by our calculations, anything over 5 is considered strong, and then the 4% is considered great for population health. So anything over 2, so we have certain benchmarks that we're, and again, we're looking for associations because we don't have the answer to your question.
Yeah, that's great. And sorry, if I may, just quickly, in terms of community engagement, because it was brought up now, and you did all mention it, and I really appreciate that. Any thoughts that you could offer on quantifying that process? I've done a lot of community-based work, and you talked about the time it takes to actually form the trust and get the work done. Any thoughts about trying to understand the gelling of a community group that comes together so we can better accelerate that process in work that we're doing to scale some of the models that you all talked about? Even if just one person comments, I'd really appreciate it. Thank you.
Good, Deborah.
We've all talked about community engagement, resident engagement, and Don, this whole notion that this is an essential element of sustainability. And early in our work around tobacco control, a lot was built around building coalitions locally, regionally, nationally, and we did a lot of assessment work about asking each of our coalition members about their connections. Because to me, sustainability is a lot about connections. One of the last pictures that you saw was of Phyllis Lucen, the resident leader, with the chief of police and the city councilman. These are connections that have happened because of the events and because of the activities of the Hill Zone. And so we used to give out these surveys and ask people about who are they connected with around this body of work, and we do it periodically to say, how many times have you talked to so many people in this last month about this issue? And what we were able to do with that data is to see that connections and relationship had actually expanded in real ways in talking to people and making connection. And that, in my mind, translates into building relationship and making things happen in the community. One of the things that we did is we put in a traffic light after doing a walk audit. One of the residents in the neighborhood came up to me and said, "Thank you for pulling this work together. It's taken 11 years for us to get this traffic light in. I've been calling the city for 11 years. Mm-hmm. Well, what made it happen was the connecting, right, of all these parties."
Let's, we keep asking questions until I get the time that we need to stop, but let's go and we'll get as many as we can get in. Please.
Hi, I'm Suzanne Lemenestrel. I'm with the 4-H National Headquarters at the United States Department of Agriculture, and I wanted to ask the panelists in rural communities, what are some of the best practices that you all mentioned that you think translate, because conception of community in a rural area could be multiple counties, and they have the same access issues to transportation and health disparities, et cetera. So I was just, I think most of the examples were in urban areas, so I was just wondering about translation to rural communities.
I think it's a great question. Don, you want to talk, because your work is,
yeah,
you've got a lot of rural.
It does have a lot of rural, and I don't have great news that I have. I have huge insights in, there's such different challenges. So for instance, in our work with food access, we have this one whole set of challenges in the urban environment. It's pre-built, you've got demolition, you've got polluted land, you've got an unready workforce, you've got all these different kinds of perceptional issues of risk. In the rural communities, what we found is just sheer distribution. Functional distribution to grocery stores was a problem. We can't get suppliers to send the truck the 85 miles to get to the grocery store when they only want to buy $3,000 worth of goods every week. And what we've seen is some of the best practices, there are new alternative models bubbling up, some of which are kind of shared buying, cooperatively owned businesses being, that's an old rural trick, right? Is share ownership, own the truck, send the truck if 5 grocers band together and manage their own distribution. And then we're seeing we presented at the White House some really interesting folks there's school-based grocery stores in Nebraska, modular stores in New Mexico and other states where people are converting either tractor trailers or RVs into mini markets that then they're at the same place every Thursday because you can't support a store. So there's some interesting models that are totally different, and they're not really kind of necessarily always for-profit, singular entrepreneur-based. They're collaborative and cooperative and very alternative in their delivery models. That's what we've seen thus far.
And I'll just jump in. One of the things we've done is we have been working with convenience stores who are located in those areas in certain cases and really are the place where people go to get groceries and things, to expand their offerings of healthier options and really working with them to try to make that a successful and profitable part of their business. And I think that more and more that industry is beginning to see that can be profitable and not something they need to struggle with. And so hopefully that will be something that catches on. Yes, ma'am.
Should have done that. Hi, my name's Krista Ridley. I'm a holistic health and wellness coach. And in my previous life, I worked a lot overseas in poverty alleviation and community development in Africa. And to the gentleman's question there, I think what I understood was, yes, there was a lot of community engagement, but I think what his question seemed to me was saying whether the needs assessments from the community are indicating that obesity is their concern for them, or their primary concern, and thus they want these interventions, or is it, perhaps it's just disease or other health issues that they might be indicating. So then how do you build from that needs assessment? It might be some of the poverty issues or the employment issues or the school issues that they're bringing up. So how do you build from there to do a obesity program, an anti-obesity program? And the second question I had with my experience from international was, on the monitoring, evaluation, measurement side, is there any cross-pollination between what international development professionals have been doing for a number of years in those areas, and how could that potentially help with your models that you're creating?
Pamela, do you want to address the second question?
Well, I was going to address the
please.
first question.
You can address whatever you want.
So to your point of that, and thanks for clarifying that we didn't get the question correctly, perhaps, I would say that obesity is not always the first choice the choice isn't the right word, the prioritized health need if you're talking to residents in a community, and that's just a fact. But speaking as a funder now, it might be where we're investing, and so so communities join for that reason because there's money along with it, and sometimes we've had to be really flexible in how you address obesity, because in that community perhaps violence is the issue, and so how do you address, you're not going to get people to go to the parks if it's not safe. So you can do all the park renovations you want, but if there are needles there, it's not going to happen, or if there are gunshots along the road to get there, or kids aren't going to walk to school, and so on. So so we've had to step outside our comfort zone because we're saying, how can we possibly address violence? That's huge, and but we can address obesity, which is also huge, but how can we address both? And so we've had to rethink our strategy and learn how to partner with other funders to address different pieces of a community's issues. But still, to your question, it's not always the community's first prioritized need. But it always is a need in that community based on data. It's just not always based on the most urgent need of those residents.
I've got the high sound. I'm trying to get two more questions in. I'm sorry, I think we're going to go to Lynn. You have a question from the audience, and maybe I'll try to get the first person in line here, and you've been standing for a while. Yes.
From Rajiv Narayan, a web viewer. He says, this is a question for Mildred Thompson of PolicyLink, but it also could be for others. What data or stories have you been able to show in the short term to funders in order to engage their long-term investment?
Okay, that's a very good question. I think that it is important for us to tell our story, and I'll just give one example. We did a report a number of years ago called Design for Disease, which was basically making the case for how our communities are designed, which continues the diseases that are formed. And one of the things that we did was a survey of people in some low-income communities, asking them if there was a grocery store in their area, would they utilize it? Now, it seemed like it's a common sense question, but overwhelmingly, people said absolutely they could use it. So using that bit of data to say, community members said that they will definitely improve their eating habits and their purchasing habits if there were choices, as opposed to their assumption being that people would choose to just eat fast food restaurants. So I think that we've got to be able to use the science and our data in a way to support what may be just norms in the community. So I think that's telling that story of people saying, absolutely, I would choose it, but you've got to get products that's going to meet my cultural interests and my cultural values. So you can't just open a store, people are going to go there. So I think using those kinds of things has been really helpful.
Okay, we got our last question. So this is going to be a good one. Pressure's on.
Oh boy, okay. My name is Elizabeth Wesley Casella, and I'm the founder of bingebehavior.com, and I'm also the leader of a stakeholders group that deals in weight stigma prevention. And there are 23 coalition members. So my question really goes to the leadership aspect and the equity aspect. In cross-sector work, as in coalition work, diversity is a must. But I often find that some of the subject matter can be very contentious. So I'm interested in knowing how you create safe spaces for dialogue and diversity, equity or lack thereof, to build what you guys have been describing as very robust organizations that tackle some very large issues.
So maybe Pamela, you and Mildred each want to take 30 seconds on this? Okay. 3 30-second, and then we'll close.
Okay, well, I think one of the first things that has to happen is to understand power dynamics. So when we're talking about who we bring to the table, everybody isn't going to be equal. You know, when we were required to have consortiums, those consortiums were required to have providers and consumers and community organizations. They have different levels of power, and people who view themselves as not being as powerful, having as much voice as a doctor, are going to be quiet. But how do you create an environment where everybody's voice is valid? How do we make sure that when we bring people together to the table that's not used to being there, that they surrender their titles and they're just coming there as a participant? So I think it's up to us to create an environment that's open and receptive so that we all see each other as having as much value and contribution as everybody else.
I would agree with that. Several of the leaders I talked to have talked about setting the ground rules for engagement, which meant letting go of your ego, letting go of assumptions about what a word like obesity means and what that conjures up in your mind. It may not be intentionally meant to mean what that person thinks. So I would agree, sort of setting the stage and a foundation for an open and honest dialogue to reach some common understanding.
And I'll say 2 things in 30 seconds. One is that agreeing with what both have said is that we're constantly looking for ways to engage residents in ways that are meaningful. And so how do you bring the resident voice into the room, into the evaluation? And one strategy that we've had for that was to use photo voice as part of the evaluation effort. And so it's where you give people a camera and you ask them to take pictures of barriers to health in their community. And then you go through a captioning process so they caption the pictures saying what they mean, what needs to change, and use those for advocacy. So we've done photo voice in that way, the traditional way, and then we've created a new method of photo voice for documenting impacts. So we've gotten the residents' perspective on through picture taking again and a slightly adapted captioning process that looks at what's changed in your community, what does it mean to you, and what do you still need to do to make it, what still needs to change in your community to make it healthier, and getting people's voice to the table and then giving them a product that they can then use to advocate for those changes. And we've seen huge results there, quick results and really meaningful change from the residents identifying the needs, the residents advocating the needs through their voice and through a photo.
Great. I think that completes this morning's session. Can we have a round of applause for the panel for the great job?